Doctors and students, without further ado, please welcome on behalf of Chief of Pediatric Dentistry Residency Program, Profesor Dr. Arlet Suzy Puspa Pertiwi, Dokter Gigi, Spesialis Kedokteran Gigi Anak, Subspesialis Anak dan Individu Berkebutuhan Khusus, Konsultan, Magister Sains, Fellow of Special Care Dentistry Association, Fellow of International Association of Disability and Oral Health. Professor Arlet, time is yours.
Okay, thank you, Naninda. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Greetings to all of you, especially to the Vice Dean of Faculty of Dentistry, Universitas Pajajaran, Dr. Sri Susilawati, our honorable speaker for today's lecture, Professor Emmanuel. It is nice to finally meet you again, although it still happens through a laptop screen. Lastly, but not least, I also would like to thank all of the head of the department, chief of all study programs here in the Faculty of Dentistry, Universitas Pajajaran, professors, lecturers, dentists, researchers, students, and participants all for joining this lecture. We are truly delighted with your presence. On behalf of our Chief of Pediatric Dentistry Residency Program, I am pleased to witness a collaboration between the Faculty of Dentistry, Universitas Pajajaran, and the dental kids. I hope that collaboration can be maintained and expanded in the future, not only for in the lecture activities like this one now, but also in other research. So as we all know that special care dentistry is a specialty in dentistry concerning with the oral health of people with intellectual disabilities or who are affected by other medical, physical, or psychiatric issues. Their additional needs may be due directly to their impairment or disabilities, to some aspect of their medical history that affect their oral health, or because their social, environmental, or cultural context disable them concerning their oral health. We recognize that only few dental practitioners in this field that can improve the oral health of people with special needs. Not only is their access to care almost non-existent in comparison to the general population, but also that the facilities are inadequate here. Staff lack awareness of oral health matters that may impact those with special needs. So to address that matters, we need more information, education, and networking to increase the access of oral health care for patients with special needs. Therefore, we hope that during this short lecture, we can exchange information to advance oral health care for special needs patients. Closing my speech, please enjoy our first expert lecture for this year. Looking forward to many more such events engaging more people on a greater level. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Arlet, for a wonderful speech. To officially begin this program, we are pleased to have our Vice Dean of Faculty of Dentistry, Dr. Sri Susilawati, Dokter Gigi, Magister Kesehatan, to deliver the opening remarks. Dr. Susi, time is yours.
Thank you, Dr. Nanin. Assalamualaikum warahmatullahi wabarakatuh. On behalf of the Dean of Faculty of Dentistry, Dr. Dudi Arifin, I am Sri Susilawati as the Vice Dean for Academics, Research, Student Affairs, and Alumni will represent our Dean to deliver his opening speech. Dear our guest lecturer today, Professor Dimitris Emmanuel, the Head of Pediatric Dentistry Department, Prof. Willy, the representative of Head of Pediatric Dentistry Residency Program, Professor Arlet, the Head of International Office, Dr. Dewi and team, all the faculty leaders, Head of Departments and Residency Programs at Unpad Dentistry, fellow dentists, lecturers, and researchers, students, and everyone present. Welcome and a good day. I am given an immense pleasure as today so many of you are taking a keen part in this special occasion. I'm sure that we will all feel enlightened with knowledge after this meeting. More importantly, I'm honored to welcome Professor Dimitris Emmanuel from Dental Kids, who will share his wisdom and expertise in special care dentistry. As we know that not all and every patient are cooperative during treatment. Some of them may have issues which may interfere our normal daily procedures. However, as dentists and professional healthcare providers, we are obliged to deliver our best of abilities in providing such care and treatments. I'm glad to note that this lectures highlights the importance of special care dentistry and its direction. To continue improving and providing healthcare, we need to combine knowledge and skills to meet the needs of such care itself. Today, we have the opportunity to expand our knowledge and gain insight in the area of special care dentistry. Doctors and fellow students, I hope this event not only trigger curiosity, but also give our young doctors and students a small foundation in pursuing excellence. Without further comments, I welcome you once again to the lecture, and I hope that you have a great time ahead. Thank you very much. Thank you, Dr. Nanin.
You're welcome, Dr. Susi. Thank you, Dr. Susi, for the opening remarks. Before we start the lecture, I would like to remind you a few ground rules during this lecture. First of all, please mute all your microphone during the lecture. Please do not use the chat box during the lecture unless it's in discussion session and you want to ask questions. Please turn on your camera and use the virtual background. You can turn your camera off if you are in a distracting space. For the participant who would like to ask a question, please write your question in the chat box with this format, your name _ your question. The question will be delivered by the moderator, or you can click the raise hand button after the lecture. You can introduce yourself and ask your question after the moderator calls you to speak. Okay, ladies and gentlemen, let me read our moderator brief resume. Dr. Gigi Prima Andi Setianto, spesialis kedokteran gigi anak, is a pediatric dental specialist and lecturer in Universitas Pajajaran from 2014, visiting specialist in RSGM Unpad, Bandung Dental Center, and also AMC Hospital. Dr. Gigi Prima gained his BDS and DDS degree from Universitas Pajajaran. In 2019, he gained his specialist in pediatric dentistry at Universitas Pajajaran. Dr. Prima have a lot of research and publication. For example, the latest is as a co-writer in a publication entitled Growth Stunting Implication in Children, a review on primary tooth eruption in European Journal of General Dentistry. Dr. Prima, are you here with us?
Yes, hello, Dr. Nanin. Good afternoon.
Hello, how are you, doctor?
I'm fine, thank you. How about you?
I'm feeling great. Are you ready, Doc?
Okay, I'm ready.
Okay, Dr. Prima, time is yours.
Okay, thank you, Dr. Naninda, for presenting me as moderator. Hello, everyone. I would like to deliver my greetings to all the participants, dentists, and students for finding time and joining today's lecture. I'm so delighted to have all of you in a visiting lecture in pediatric dentistry today. And our topic for this afternoon is future direction of special care dentistry. And we will have the honorable lecturer of the day, Professor Dimitris Emmanuel, DDS, MS, PhD from Dental Kids London, to deliver the topic for us. First of all, let me read Professor Emmanuel's brief resume. Professor Dimitris Emmanuel is a specialist pediatric dentist currently working in private practice and teaching. He was assistant professor at the Department of Pediatric Dentistry Dental School, National and Kapodistrian University of Athens, Greece. Also was a senior lecturer of King's College Dental Institute, London, UK, and then a clinical direction of Dental Kids, a group of dental practices in 3 European countries, Greece, Italy, and UK, dedicated to pediatric dentistry and orthodontics. He completed the pediatric dentistry postgraduate program of Children's Hospital of Wisconsin's Medical College of Wisconsin, USA. He also earned a master from Marquette University, USA, a PhD from the University of Athens, Greece, and a certificate in epidemiology from Harvard Medical School. He is being invited internationally to lecture on nitrous oxide, spatial care dentistry, and behavior modification, and he has lectured annually at Harvard continuing education courses in USA. And today, fortunately, he will be sharing his expert experience entitled Future Direction of Spatial Care Dentistry to us. Before we start, please allow me to remind you, if you have any question during the presentation, just write down in the chat box, or you may use the raise hand feature in Q&A session. Now we are pleased to welcome our speaker, Professor Dimitris Emmanuel. Hello, Professor. How do you do, Professor?
I will say good morning since I am in London, or Selamat Hari.
Okay.
And Salam Alaikum. It is indeed a real pleasure to be here, although I would prefer to be in 3D in front of you. And hopefully at a certain time, I will be able to visit Indonesia again. I have been to Surabaya some years back lecturing, and I was really amazed by your hospitality. And as you know, I'm Greek, so Greeks are really keen in philoxenia, which is the hospitality. So I'm really amazed to see how we interact with each other. And I will be happy to share some what I think will be a little bit also provocative ways of seeing special care dentistry today. And depending on how much time we have, I can expand or not expand, and we'll see how it goes along the way. And if we're not done for today, maybe at a second lecture we'll do some more.
Sure, Professor.
Thank you again.
Okay, Professor. The presentation is around 50 minutes, followed by 15 minutes Q&A question. Okay, are you ready, Professor?
Yes.
Okay.
Please, shall Professor. Can I share my screen or? Okay.
Yes, please. Yes, please. Time is yours, Professor Emmanuel.
Okay, thank you. So I assume everybody's seeing my screen now?
Yes, we can see it. Okay,
excellent. So thank you so much for this kind introduction. So I don't really need to say anything more. Let me see if, as you said, I'm the director of Dental Kids now, and I'm also the president of the Hellenic Society for Disability and Oral Health. And we have the meeting for the International Association for Disability and Oral Health this August in Paris. So if anybody can come to this direction, I don't know, maybe some from your group of faculty or students already arranged to be there, it will be a pleasure to meet them live. From what you'll see, I have no financial relationships with anything that you will be seeing today. This is our dental school in Athens. I'm now retired from Athens, but from the back of my office, I could see in the far end the Acropolis in Athens, which was a really interesting view to have. What I'll be talking about is, as you asked me to do, the future of special care dentistry, and I think we have to start a little bit by reframing disability. Let's think a little bit about a paradigm. A paradigm is a set of assumptions, concepts, values, and practices that constitutes a way of viewing reality. And this paradigm can be really interesting. If you look closely, I'm sure at first sight, somebody will see a beautiful young woman, and some others will see an old woman. And I'm sure it's, unfortunately, it's not interactive, so I cannot see hands of who sees what, that's a really interesting way to see. Or what about this image? Some people may think is a rabbit, and some think it is a duck. So our perception is always ours, and is this paradigm that we need to be shifting. And we do know that the medical model that we have has already shifted from disease management. We are talking now about concepts of quality of life, behavioral aspects of health, and this model, the World Health Organization has recognized, and from disease or disorder and impairment and disability and handicap, it moved to a different classification, which is called the International Classification of Functioning, Disability and Health. In this model, disability is treated as a continuum rather than categorizing people with disabilities as a separate group. And this is really very important on how we view our patients, and how, and if we view our patients in a different way, we can treat them in a different, or confront them, if I may use that word, in a different way. So the ICF paradigm tells us that human functioning is universal. Functioning is human experience in relation to the interactions between a health status, a social and environmental contextual factors. Disability is also a human experience in relations to the interactions between health status, social and environmental contextual factors. So if we look at that framework, the health condition is one thing, and it has to deal with body function and structure that may have an impairment. It has to deal with activities that may have a limitation, and it has to do with participating in general aspects of life, which may have a restriction. And to this, what clicks in is the environmental factors, where a person actually lives and their surroundings, and also personal factors for that particular person. So all this is the framework that we need to acknowledge before we decide. And I will give you a paradigm that a group of esteemed colleagues that are working a lot with special care did a few years back. Using the International Classification of Functioning, you can see here a Down syndrome person that has a Q90 International Classification of Disease. And I'll talk a little bit, I'll explain in a minute. So we have the International Classification of Disease, and this is a Down syndrome, right? So the body structure has potentially, as far as we are concerned, we're not concerned about any other issues that may affect this person. But as far as we're concerned, the human function, we have potentially an underdeveloped maxilla, malocclusion, a hypotonic tongue. So this is the classification of the ICF, the International Classification of Functioning, is the structure of the mouth. The body function is impaired mastication, which is B5102, the chewing, B5103, manipulating food in the mouth. Eating, the activity, is unable to chew. Participation, the person cannot sit in a canteen, and that means he has an impairment in socializing. And then we have environmental factors that may affect this condition, as far as mastication, correct? And as far as the activity of eating, we can have helpful or unhelpful canteen staff. So it's individual attitudes or personal care providers. And this is what I will focus a lot more today in this lecture. And finally, the personal factors, that sensitivity to unkind remarks, that there's yet no code for it in ICF. So disability is a matter of more or less, not a yes or no. So all of us at a certain point in our lives, and hopefully if we're lucky, is going to be late in our life, will have some form of disability, because certain systems in our body are not going to be functioning as they're functioning when we're young. So disability is not considered an illness, but is defined according to how a person fulfills her normal social role within a given environment. And obviously, these guys definitely have no disability as far as running. They're probably running faster than I do, definitely at this point. Maybe when I was younger, I could take over some of them, but not all of them. So disability results from the interaction between persons with impairments and attitudinal and environmental barriers that hinder their full and effective participation in society on an equal basis with others. And we have to distinguish between the two classifications, which is the ICD, which classifies the disease, and ICF, which is actually classifies the health of an individual. And of course, as we know, and it's been noted also previously, there is evidence that oral health services can improve the quality of life and the general health by providing environmental facilitators to the reduction of disability according to this international classification of functioning model. The ICF core sets for oral health. It's to collect reliable, reproducible epidemiological data comparable between local and international communities, clinical assessment for therapeutic and research purposes based on a patient-centered model, recognize the special oral health problems and needs of subgroups of specific populations, identify the functional and environmental determinants of oral health for specific groups again, improve communication and collaboration between medical and social professionals, patients, and policymakers. We cannot manage what we cannot measure. So it's very important to measure and then be able to make decisions based on data. Provides patient-oriented perspective in the negotiation and planning of oral health services, assess oral health services and treatment outcomes, including public health measures, prevention and health promotion, and of course, develop the dental curricula from a holistic perspective so the students, our students of the future, get the best training in order to help their patients. That's another article back in 2015, pretty much from the same group that described children from 0 to 16 with disabilities receiving pediatric specialist dental care from a biopsychosocial perspective with focus on the relationship between oral health, medical diagnosis, and functioning. And the two factors that they were calculated was the physical ability, intellectual ability, communication, and behavior. And they saw that despite complex disabilities, the children had good oral health because neither the medical diagnosis nor the functioning was found to have a clear relationship with oral health. So this is a study that will untangle certain issues as far as to what is disability and oral health. In other words, people that we may be considering today as disabled or special care, they may not be actually disabled as far as we are concerned with our oral health. So you cannot say that a person that has a specific disability is also a special care person for dentistry. So this is the point I'm trying to make. So who are the individuals with special needs in oral health care? If we analyze the ICF classification, we have three specific groups with relation to oral health. Persons who experience disability due to impairment of oral function and or structure, and who are limited in their activity or participation directly by their oral status. For example, patients with caries, edentulous patients, patients with cleft lip and palate. Persons with a health condition that has direct or indirect repercussions on their oral health, like people with multiple sclerosis, autism, dementia, that they cannot function and they need and that as a result affects their oral health. Finally, persons whose oral health is negatively affected by their social, environmental, or cultural context, like new immigrants, persons with no home, homeless persons, and these groups. So if we try to do a definition based on the second and the third groups of the ICF terms, items, then the characteristics of individual with special needs in oral health would be persons with a disability or activity restriction that directly or indirectly affects their oral health within the personal and environmental context of the individual, persons living in a social, cultural, or environmental context that directly or indirectly affects their oral health in relation to the social determinants of health and to barriers experienced in accessing healthcare and prevention. Why changing this model is important? It is important because we have to focus. We cannot be seeing people with different medical conditions as also people with special care interest in the oral health. What we have to focus is why something that affects the general health or the specific parts of health of an individual affects their oral health, and that's where we should be focusing. As in general rules, we know that approximately 15% of the world has a disability, and we know that this prevalence will be increasing, as I said, because the age of the population is increasing. So a lot of people will need access to oral health. Also, the global increase in chronic health conditions like diabetes, cardiovascular diseases, cancer, and mental health disorders increases, but also we have, and now probably long COVID. So all these disorders that we know how to treat them or make them chronic, that means that we're going to be seeing a lot more patients that will have effects on their oral health and living longer. So this population will keep rising, will increase. Let's talk now a little bit about barriers. And we all know that there are barriers and inequalities to persons with special needs. And we can put them into individual barriers, environmental barriers, and what I put here, and I'll explain in quite a bit of this lecture, of this discussion, a willing professional. So we pretty much know about individual barriers related to the individual, may not have access to oral examination, oral prevention, or dental treatment due to lack of cooperation, due to cultural and social barriers. Individuals may have difficulty expressing their oral health needs due to cognitive or mental disorders, or again, due to cultural or social barriers. Individuals may just plainly not brush their teeth and may fail to be reached by national groups' measures of oral prevention, again, due to their cognitive or mental disorders or other cultural or social barriers. Environmental barriers is what we said. Appropriate services will not always be available, either because there's lack of services providing, for example, dental care under sedation or general anesthesia that will be needed for a group of these patients. patients may be left untreated, or if they are uncooperative, may be treated under restraint. And these patients tend to receive more surgical interventions like extractions than conservative care. Several countries propose financial cover for the potential additional cost of treating patients with special needs, but these are indeed very few. Environmental barriers is also the majority of general dentists declare that they are untrained to treat these patients. They claim they are unable to treat patients with special needs, and they will refer these patients to another structure or practitioner when it's possible. And that, of course, creates a bottleneck into treating patients. But let's also discuss something, since we are still in a dental school. How well are we preparing future practitioners in terms of training experiences, even in their personal attitudes regarding individuals with disabilities, to meet the complex needs of this vast array of persons with disabling conditions? This is in 2004, and it hasn't really changed much. Half of the graduating medical and dental students had never treated a patient with disabilities, and that's in the United States. In 13 dental schools in the US, dental students are strongly motivated to learn about providing care for patients with special healthcare needs. Their confidence was correlated with their intentions to include these patients in their patient families in their future professional lives. Please consider this. The better their dental education prepares them for this task, the more likely they will be to provide care for these patients. This is what this group found out back in 2011 in Journal of Dental Education. But same thing, we did one in our school, and we saw that our students are eager to have theoretical and clinical training in treating special care patients in the last part of their studies, but the curriculum does not satisfy these needs. They usually need to cram a lot of other knowledge, and I guess implants is now the part that takes a big part of this training. But in order to continue this discussion on yes, students want to have more training, and indicate in this other paper, students indicated that their previous experience with individuals with intellectual disabilities, assessment of their general capabilities and dental capabilities, and current and anticipated comfort levels related to their treatment, they indicate significantly higher expectations of general and dental capabilities after instruction. So they know how to do it if they are trained. But there was no change in their comfort levels of treating patients with intellectual disabilities. And I've seen this with practically the majority of my residents in pediatric dentistry, and that they were treating the children with special needs. So the coursework in special care creates an awareness of the relationship between socioeconomic disparities that impact access to dental care, initiates a culture and self-awareness, but it does not create a willingness to care for vulnerable populations. Students often view the needs of vulnerable populations as being distant from themselves. So when the students will go out in the private sector, that's mainly what happens, but also in more controlled public health sector, they try to avoid treating patients with special needs. This is from a lecture I gave in Taiwan before COVID, and this was Professor Sheng Te, that he was giving exactly what I was talking, and that's why I took a picture of that slide. The willingness of dentists increased due to continuous education. The willingness of the dentist to treat patients with special needs increased from 2006 to 2007 because we conducted continuous education and provided a supplemental fee in treating these patients. So in Taiwan, what they did is they gave incentives to the dentists to treat special care patients. And that may be a way to do it. There was also an editorial not long ago by Professor Ackerman, who was an editor of the Special Care Dentistry journal at that time. Is special care dentistry a dental specialty or a dental special interest group? The reason there was this editorial was exactly because when we start doing special care dentistry only as a specialty, and this happens not so much with pediatric dentistry, but with maybe some other specialties, general practitioners, general dentists tend to rely into their specialized colleagues to deal with the problem. So the untoward sequela of this end game would be the reinforcement among general practitioners and other specialists to let someone else treat these patients. So it is very tricky to find out what is the fine line that we can have the specialty and what the specialty as of special care specialty is going to be doing, not preventing from general practitioners in actually treating the vast majority of people with disabilities that can be treated by general practitioners. And in 2013, when I was president of the International Association for Disability, I wrote this editorial: for access to care, attitudes are the real disability. And I will expand to this. Eunice Kennedy Shriver, that did the Special Olympics, said at a certain point, it is a sad fact that many dental professionals have shed away from treating patients with special needs. Too often, patients with disabilities have been perceived as someone else's problem, but someone else wasn't offering solutions either. We want every citizen with special needs to have quality oral health care. And Waldman and Perlman, who were the people that did the special healthcare athletes along with Special Olympics, they wrote also an article to that extent, let someone else do it. So we go back to the third barrier where I put as a willing professional. And as Scott Hamilton, who was a cancer survivor, said, the only disability in life is a bad attitude. And attitudes is a mixture of beliefs, thoughts, and feelings that predispose a person to respond in a positive or negative way to objects, people, processes, or institutions. And we know that a lot of attitudes that we have are bias. It's prejudice. Prejudice is the unjustified, typically negative attitude towards an individual or a group. As this little story says, define biases, a careful review of the facts, which results in any viewpoint other than my own. So what we perceive as true and right is our bias. Implicit bias refers to the attitudes of stereotypes that affect our understanding, actions, and decisions in an unconscious manner. And this is something that we need to really look carefully into. Because implicit biases reside deep in our subconscious. They are different from known biases that the individuals may choose to conceal for purposes of social and or political correctness. It's prejudice, it's stereotyping, and it's discriminating. And stereotype is an overgeneralized belief about a particular group of people. These implicit biases encompass both favorable and unfavorable assessments, are activated involuntarily and without an individual's awareness or intentional control. Listen to this.
Bias often runs counter to people's conscious, expressed beliefs. Few physicians espouse racially discriminatory views, and yet doctors tend to recommend less pain medication for Black patients than for white patients with the identical injury. In other words, people can be explicitly unbiased, yet implicitly biased, according to psychologist Daniel Kelly and colleagues. Bias.
And what about
one of my closest friends since high school? We've worked on a lot of projects together. We've been in a lot of classes together. Sometimes we'd be working together in a group project, for example, and she would say stuff like, oh, you're good at math, you're good at science. Here, you can take this part of the project or something. I don't hold it against her or anything, and she doesn't mean any harm by it. But obviously, there's that implicit sort of bias or stereotype that Asians are better at math and science.
So I think you understand where I'm going to. So when these stereotype beliefs combine with prejudicial attitudes and emotions like fear and hostility, then we are in trouble. Like, I'm lazy because I'm fat, and I'm fat because I'm lazy. So it's very easy to say, well, fat people look lazy, and that way they're unemployable. And then what happens is the prejudice, which is an attitude, becomes a discrimination, which is a behavior. And this is something that we need to look really a lot into it. So attitudes to disability are the major barriers to disabled people's full participation, from pity, awkwardness, and fear to low expectations about what disabled people can contribute. Stereotypical and negative attitudes hold people back. So these biases can affect how we treat others, because we have implicit thoughts and explicit thoughts, and explicit biases will be expressed directly. People will be aware of that biases, both for them and the other people for them, operates consciousness, and it's expressed. So, for example, I like white people more than Latinos or Black. Implicit biases is expressed indirectly. The person is usually unaware of that biases because it operates subconsciously. For example, you walk into a cafe and you sit away from a person that you subconsciously don't like, a group of persons like a Latino or Black or a person with disabilities. And you tend to go to your peer group near. So the key characteristics, as I said, they operate at the subconscious level. We don't know that we have them. Everyone possesses them, even people committed to be impartial, like judges. They run contrary to our conscious beliefs. You'll see dental students that they will say, yes, I want to treat special care patients, but when the time comes, or if they can avoid it, even subconsciously, they will not. I will give you also an example. I will give you some words in the next couple of slides. And I want you to think what comes in mind when you see these words. Government, industry, professor, Lee, a name. Now, all of us, when we hear these words, we associate them with what this word means to us in a subconscious level. But then, when, let's say, I walk into the podium today and I tell you that Slamat Hari, I am Professor Lee, I work in a government dental school, and I'm here today because industry has paid for me to be here. You have already put a label on me because you heard this particular trigger words that for each one of you has a totally different meaning. And this will create a predisposition for me that is totally different from the disposition that the person next to you sitting has. So if you do this, if you start thinking about it, then you'll understand what we're talking about, implicit biases. As I said in the previous, there is also one of the key characteristics is this in-group, out-group phenomenon. So we generally tend to hold implicit biases that will favor our own in-group, what we believe about ourselves. Harvard has done a really interesting project, and I will ask you at a certain point to go in and play with this, not only for people with disabilities, but for other groups, social groups that are having issues. Here we're talking about, of course, about social attitudes, mental health, etc. So it's the project Implicit. So what they do is you're going to play a little game in the computer, and I did here my game, and I consider myself quite positive in attitude. I mean, I've treated patients with disabilities all my life. I've been the president of the International Association for Disability and Oral Health. I definitely, think I have no biases against or towards disabled persons. But I played that game, and I played it, it's been some years now that I did, I haven't repeated it. So you click on the computer as it goes along, it flashes images, and you have to click, put the left finger on E, the eye, and if you make a mistake, a red X. So it gives you some words, and you have to put them. What's bothersome? Is it bad? Is it good? Is it? So the computer will play along. So you see, as long as they're bad and good, no real mistakes are made. And you see how fast this goes. Then we add bad or disabled, good or abled. And to go a little bit further, now it's switched. It has abled and disabled. left and right. And now it switched bad, enabled, good, and disabled. And let's see if I can get out of this. And I was really stunned with the result, because my result, your data suggests a slight automatic preference for able persons over disabled persons. So somewhere in the deep conscious of mine, I am programmed to think some thoughts that they shouldn't be there. And we all, I'm sure, if you go to this little game for a lot of other things that you think, I don't know, you can talk about, you know, people of color, people of different sexual orientation. So it's an eye opener for the implicit bias. So having thought about this and discussing it with the board, we decided to make a task force back in 2013 to develop and validate a set of questionnaires, sort of similar to that in Harvard implicit bias, that might be used to evaluate attitudes within special care dentistry. So this project has involved identification of pre-existing measures and attitudes from different questionnaires and tools. And then we piloted them in different groups of students in Ireland, Canada, the UK, and Malaysia. And this is what came out, a development of battery tests to measure attitudes and intended behaviors of dental students towards people with disability or those in marginalized groups. And you're welcome to look for that. If you can't, you can give me and send me an email and I'll send it to you. In this toolbox, there are 4 questionnaire sections. One is the integrity questionnaire, was designed to evaluate the integrity of the responder, like, in your opinion, are the following activities ever justified? Avoiding paying the fare on a public transport, which is something minor, right? Falsifying your CV, which is something a lot bigger. Altruism questionnaire. How strongly do you agree or disagree with access to oral health care is a social good or right? People with disability in general do not contribute much to society. Attitudes to healthcare questionnaires. Treatment of patients with disability is too time consuming. It is glamorous to treat patients with disability. And then it was a questionnaire that was designed to use the core concept of the theory of planned behavior. And I'll talk to you about planned behavior, or I'll give you a little video to understand. And this section, the dental educator chooses one of the 12 listed clinical scenarios to use in relationship to the questionnaire. So the theory of planned behavior is actually that the behavioral beliefs and the attitude towards the behavior, the normative beliefs and the subjective norms, and the control beliefs or the perceived behavior control gives you the intention, which in terms will produce a behavior. And I have this little video that has to do with a gym, and listen to this. And I think this will be a perfect example if you extrapolate that to people with disabilities.
Theory of planned behavior. Intentions are the product of 3 different processes: behavioral attitudes, subjective norms, and perceived behavioral control. By the end of the presentation, you will hopefully understand the different predictors of intentions according to the theory of planned behavior. We will also apply a real-life example to the theory, helping you to recognize how this might be used in a day-to-day scenario. According to the theory, the first predictor of intentions are behavioral attitudes. This relates to how a person thinks and feels about the behavior and reflects their expectations and evaluations of the behavior. This can be split into two different aspects: affective attitude and instrumental attitude. What do we mean by affective attitude? Well, this could be whether a person believes the behavior to be enjoyable or unenjoyable. In an exercise situation, this might be the extent to which a person enjoys going for a run. Whereas instrumental attitude refers to whether the behavior is believed to be beneficial or harmful. These are not always clear-cut, and an individual might have a mixture of affective and instrumental attitudes. The second predictor of intentions is subjective norms, which relates to the support given or not given by family, friends, or significant others, such as a GP. Similar to attitudes, this can be split into two different types: injunctive or descriptive. Injunctive norms refer to whether others encourage an individual to do the behavior, and descriptive norms relate to whether others in a person's social group engage or don't engage in the same behavior. The third and final predictor of intentions, and an additional contribution of the theory of planned behavior, is perceived behavioral control. In sport and exercise psychology, control is an important variable. Within the theory of planned behavior, the extent to which a person feels capable and has confidence in their ability to execute the desired behavior will play a central role in their intentions and actual behavioral outcomes. This could be likened to the perception that a person has the capabilities to overcome potential barriers and challenges. Let's consider the theory as a whole. It states that when a person perceives an activity as enjoyable, with good benefits, where they have the support and encouragement of others, as well as members of their social group that already engage in the behavior, and ultimately feel that they have the ability to meet the demands of the task, they will form stronger intentions and be more likely to engage in the activity.
So if you, instead of the gym, you put treating patients with disabilities, then you understand what we need with the three things that we need to have in order to engage in this behavior, or a new dentist will engage to this behavior. We also did a joint test, let's say, of the attitudes questionnaires to investigate the role of education and training provided to undergraduate dental students by their institutions in shaping their attitudes towards patients, and set groups in two countries that have distinct cultural differences, although their flags are fairly similar, as you can see. 300 students in the School of Dentistry in the University of Athens and University of Turku in Finland. We had 100 and something questionnaires. Integrity questionnaires, less honest than average, unfortunately, is what the Greeks were talking about. Respect for public rules. Greeks are notorious for not respecting public rules. But the integrity in the self-interest categories, they are pretty similar. The same thing with altruism and the categories of altruism. So there weren't many great differences, and the distribution of the HIV patient scenario, whether somebody would treat an HIV patient, they were nearly totally similar, no differences there. How difficult was make to this decision? It was a lot easier for the Finnish group, and the reason was, as I said, both groups scored well in integrity, altruism, and attitude to healthcare. The majority of the groups would treat the patient with an HIV, but it was easier for the Finnish students because they had received the training to proper care for special care patients. And that goes to the theory of planned behavior. They had the tools to do it. Both groups believe in the need for more training in the subject. And if we can put results of this questionnaire, stress the importance of education and training by dental institutions regarding the people with disabilities and marginalized groups. So is there hope for change in this attitudes game and the way we treat special patients? In 1937, only 1/3 of Americans that they were polled said that they would vote for a qualified woman to be president, while by 2007, this figure was up to nearly 90%. Yes, there is change. Implicit biases are malleable, our brains are incredibly complex, and the implicit associations that we have formed can be gradually unlearned through a variety of de-bias techniques. So going back to our initial reframing disability, attitudes are directly influenced through questioning, personal experience, and positive or negative reinforcement, are indirectly influenced through social learning and observation, or by learning through association. So these major mechanisms, learning about the other group, the out group, behavior-driven attitude change, forming more positive attitudes after cooperating in a learning task, in-group reappraisal, generating affective ties. Generating affective ties includes the formation of close friendships that seems to be most effective in reducing prejudice. So this is a group of things we did, again, to all the schools where we had children come in, I'm not gonna bore you with this, and discuss about children with neuromuscular diseases in the class, fix a wheelchair and set it up, play around with a wheelchair, one child moving the other, and then playing games with it. So at a young age, we could see how children will understand better the other group and be willing to be together. There was a big impact of this program in changing the beliefs, attitudes, and knowledge of school children in accordance to special care patients. Since attitudes are so complex, interventions must be also have a wide range. It is important to understand what each intervention can bring to change behavior and attitudes and how these interventions interlink. Another way of doing it is like these groups, school groups, they went to a outside place and they all did a painting together, working with patients in wheelchairs with muscular dystrophy, forming close friendships, and this appeared to very effective in reducing prejudice. Disability awareness is required for all, but how it is also carried out is important. The impact of it of the training should be evaluated, and also the media may play a larger role in determining attitudes in the absence of personal experience and contact. We always have these attitudes. When we talk about male figures, we're thinking as a leader, as a provider, assertive, strong-driven. And when we talk about female, it's more a role of a supportive, emotional, helpful, sensitive, fragile, taking charge, taking care. You can summarize it. It's a really interesting way of testing whether you have an attitude or a bias towards it, is to flip it. So you see now the female is the leader, the provider, the assertive, strong driven. How does that, and the male is the supportive, emotional. How does that deal with? Being called a policewoman doesn't bother me at all because I know it covers both women and men. This is Andrew, a police woman, aged 40. So we have to see the world differently in order not to miss opportunities to serve. And this is also, we have to rethink how we educate our dentists. There's already universities that, like Still University in Arizona, that the university selection is not only done by grades, but it's also done whether the students have any done any community service. If you haven't done any community service, you don't belong to the dental school of the University of Arizona. A lot of dental schools now are doing other initiatives like the Global Brigades. This is my son in Ghana, while he was still at King's, is what we call the cultural competency training. We also did an article, again, from an international group, a global probe into dental student perceptions about philanthropy, global dentistry, and international student exchanges. And nearly all the students across countries agreed that volunteerism and philanthropy are important qualities of a well-rounded dentist. And only 1/3 felt that their school supported these behaviors. They felt that dental schools are morally bound to improve oral health care in marginalized global communities and should provide students with international exchange missions which would enhance their cultural competency and encourage their participation in charitable missions after graduation. And of course, Special Olympics is changing the world. This is from the Special Olympics back in 2011 in Athens, and then other Special Olympics that we did in groups. And the most important is breaking down barriers. Now the Special Olympics reaches 1.2 million participants in unified sports. So all these guys and girls, all these people that play together with people with disabilities, intellectual disabilities for that part, they have friends and they interact with these groups that they never had the chance to do it previously. So understanding and promoting the values of basic human rights, equality, autonomy, dignity, and solidarity is essential if governments and individuals are to commit themselves to ensure that each and every person can access the conditions required to live as self-determined individuals. I will stop here, and I think I filled my time, so I don't know.
Yes, Professor. Actually, you still have about 2 minutes, Professor.
Okay, then what I'll do is I'll stop here because there's not enough time to go into a totally different chapter. So I think we can open. Thank you so much for this opportunity to discuss a topic that is really into my heart, and I hope I touch some young people discussing this. So I will get off now. And
I'm sorry, Professor.
Yes.
I mean, you still have 1 more hour. It's 2 hours presentation. Yeah. I'm so sorry. Yeah.
All right. All right.
You still have one more hour.
Okay, because you said, and I looked in my, okay, then I'll...
it's by my mistake. I'm so sorry.
No worries. Okay, super.
Okay.
I'll continue then. Let me find.
Please.
So, okay, excellent. So, while negative attitudes to disability persist, there's also evidence that attitudes to disability are improving. And a clear relationship between attitudes and personal experience of disability was found in many other studies worldwide. Negative attitudes towards intimate relationships for people with disabilities indicate that people with disabilities are still not fully integrated within the society. But now we have also corporate that are making strides to that extent.
Shaquem, get in here. Thank you, Razor. Yep. All right. Up and down, never side to side. Shaquem, you got it? Get back. Keep second behind your brother. Stay focused. Can't nobody beat you. Ain't nobody beat you. Okay. That is Shaquem. All right, let me see.
So, and if you look into, if you look into the global advertising scene, you'll see a lot of this advertising. And this is also from a French group. So I think this summarizes all this first hour. And now we can go talk a little bit about treatment and the goals of care. So we all know that now, especially in this modern age, the goals of care are changing. In the past, we would listen to a patient and he would actually tell you the diagnosis, the patient or the child or the patient's guardian. Now, you listen to the patient, but he's telling you his treatment goals. He doesn't care about the diagnosis. What matters to the patient is the function, the social participation, and has nothing to do with clinical or health service targets. And that's exactly going to the first slide of this presentation, is that the medical paradigm has shifted. And this global shift in societies striving to care equally for all its members, and in healthcare professionals need to find ways for equal access, equal standards of care for all people. So the provision of outpatient care for patients with developmental and intellectual disabilities, as well as complex medical problems, is recognized as being particularly challenged. And these are the NICE guidelines, the challenging behavior and learning disabilities for the UK. The aim, again, is to increase the quality of life as well as reducing behavior that is challenging. They talk nothing about dental disease or periodontal disease or any other medical terms. Everything is now quality of life. And we have to think that the parental expectation and the society changes have shifted. This is how I used to train nearly 40 years back, 35 years back in Children's Hospital of Wisconsin, an open bay. This is just no gloves for the purpose of the, I'm down here. Obviously you can't recognize me. This is just a photo opportunity. It's not real treatment, obviously. And when I went back to Greece, I did my surgery as an open bay, and following this. Back then, no parent was allowed in the operatory unless the child was less than 3 years of age. We had a technique that it was called hand over mouth, and we would, it's now in no use because you can't have any consent, and it has been overused and abused. But a lot of times it would work with younger children, that they would be scared and they would block the panic attack. And more importantly, we wouldn't do more than 25 or 30 general anesthesia cases a year and 50 to 60 sedation cases a year. So very, very few. But we have to realize that society has changed, and people are now looking more to protect their children, and whoever is in school will kind of relate to this. And we used to have the helicopter parent, the parent that would protect their child, hovering above them and rarely out of reach, whether their children need them or not. But since transiting from the boom generation to the Gen X generation, and the baby boomer who was the helicopter parent, now the Generation X is the stealth fighter parent, who is even more protective. He's digitally keyed. He will Google everything in order to know the latest, hopefully he thinks. Sharp eyes on the target and ready to strike at a moment's notice to defend their children's interest. And before you know it, this stealth parent is also the lone mourner. He will take away everything. He will mourn all obstacles in front of his child. And obviously, this creates a lot of problems on how we will be able to treat our children. And of course, from this easy environment, we have moved to this more complicated and more complex. And then with COVID, the last couple of years, this has been even worse. So we have to find a way to put our patients at ease. In the past, we used to have to suppress and restrain patients' uncooperative movements, especially when we were talking about special needs. Now we're trying to guide and induce patient cooperation. And that's why if you look at old textbooks, they would be discussing behavior management techniques. Now we're talking about behavior guidance techniques. And behavior guidance, is it an art? Is it a science? Yeah, it's actually an art based on science, though. And we do know that our society has become more and more reliant from day one to from day zero to day zero on drugs. But we need to look beyond the drugs and see what non-pharmacological strategies can deal with to optimize the procedural care in children and also special care patients. And this is an article, again, we wrote with a group of colleagues, and I'll be happy to send it if you can't find it and you need it. So the non-pharmacological procedural care is an attitude of patient communication with children directed towards mutual confidence and engagement. And this is an interdisciplinary approach. It will involve definitely other physicians that for special care, there are sometimes many, other caregivers. It has to be an individualized approach. You cannot stamp, you cannot put a group approach on this. One of my professors always said that if you've seen a child with autism, you have seen one child with autism, because every child with autism is different from the child next. And we have to consider all available techniques, but consider them, not necessarily try all available techniques. And that's also very important. The process has to be a caring and relaxed environment. There must be empathy for the patient. As I said, we need to involve the family and the caregivers. You need to select appropriate time of day for that patient, appropriate length of appointment for that patient, appropriate procedures. And the first thing you need to do is try to behavior modification, as we started discussing. And of course, you can't have non-pharmacological strategies if you don't have a painless procedure. That means painless non-traumatic local anesthesia, if this is needed, and painless treatment. And the key points, as the American Academy of Pediatrics stresses it, painful or stressful medical procedures mean a substantial burden for sick people, children. Scientific evidence indicate that non-pharmacological strategies are an essential part of a procedural comfort care. So even if you end up doing sedation or general anesthesia, you need to have non-pharmacological strategies in place in order to reach without issues that part. And I'm sure the older in this group that are treating patients with disabilities, even if they have to do it with sedation, they first need behavior modification and non-pharmacological strategies in order to accomplish that. Non-pharmacological strategies may decrease the need for procedural sedation, but as well, as I said, enhance the effectiveness of procedural sedation. So sedation and general anesthesia is not a panacea. It's not something that you do. You slap a mask on a patient, or you stick a needle on a patient and automatically falls asleep and nothing happened. So non-pharmacological strategies is an important part of what we do and should be embedded into a family-centered care-directed policy. And we have to deal with three issues. First of all is the fear. So we need to remove the negative stimuli. And if this is not enough, then we have to move into procedural sedation. The pain, we need to have, if we think we're going to have pain, we need to do instant analgesia. And if this we think is not going to work, then we move into procedural analgesia together with the procedural sedation. And then the focus, we need to shift the focus of the patient by distracting him, if possible, and guiding him to a different outcome. But no matter what we do, we have to prepare ourselves correctly, to have the correct management, and to have painless procedures in order to do it. The environment-directed strategies means non-threatening surroundings, non-threatening first contact with the patient, know the medical, dental, and social history, get to know what we're dealing with, and establish a rapport with our patient. These are some photos of our practices. There are children's, kids are playing or hiding, and or it's an open bay. Medical equipment is maximally hidden or integrated. It's a non-threatening environment. And there are a lot of tips to do that. If we're talking more about children, child-sized furniture, entertainment, videos, toys, and etc. As I said before, our patients now are seeing a photo pretty much like this. We can change it a little bit with a TV on the ceiling and clear out this. We know that changing the environment and this has nothing to do with dentistry, is MRIs, acquiring structural MRI data in very young children with autism without the use of sedation, just by changing the environment of that MRI machine and creating it like a sleeping quarters and playing quarters, like Thomas the Tank Engine. We can prepare our special care patients with social stories and pictures. And we know that this works a lot with people with autism. Visual pedagogy is a type of behavioral guidance that takes an advantage of the ability of children with autism to respond better to pictures rather than words. And of course, as I said previously, there's been a total shift in the way we perceive digital context, and there is a lot of it to be able to use. Like here again is from pediatric emergency care, using a tablet computer during pediatric procedures. This is another young child that is having this app that actually is replacing herself with her app. So she's writing to me, help me, so painful. It's not really painful, but she's kind of playing. We haven't even started yet. But you see what I mean. Children and special care, they have now a lot of ways to deal with the first part of the treatment, the introduction of treatment. Then is the correct management. We need to have a correct treatment plan right for the individual patient, good planning, good preparation and execution of treatment on every visit that we are thinking of. Apply the necessary behavior management techniques to alleviate the anxiety and fear, and finish the completion of treatment as a pleasant experience. Behavior modification techniques for behaviorally challenged patients, it's practically just adapting the skills we use every day. Most people, 80% of them with mild or moderate disability, can be treated successfully in the general practice setting. We shouldn't forget this. Communication is the key to that. Eye contact. If we can have eye contact with our patient, that's a good indication that the patient pays attention and can establish communication with us and then follow directions and instructions. Non-verbal communication, which is 65%, range of behavior and environmental factors, which often interpret without conscious awareness, is the facial expression, the clothes, the bodily contact, the gesture, the gaze, and the spatial environment. Reinforcement of other communication strategies through appropriate contact, the posture, the body language. They are techniques that we use in order to gain and maintain a child's attention. And we have to establish a rapport with a young patient. We have to understand the way the child and the level of the social, emotional development and cognitive function that our patient has. Sometimes the same age, or when we talk about people or children with disabilities, we're actually talking about children of a younger age. So we have to treat them as children of a younger age. Those maturity levels is very important. And then a pleasant experience can be achieved by adapting the approach to the level of the maturity rather than the age that you're seeing. The first visit, as we said, it has to be in a non-threatening environment. Taking the patients outside the treatment room can help them put at ease and use items such as a book or website to build rapport. Our tell, show, and do that everybody knows in special patients, our emphasis is the tell, feel, do technique. So we have them touch things in order to understand what they're doing. Simulation, videos that they can play
My mom says you were going to wiggle out one of my
This is a
teeth,
video about
and I've never
nitrous
had this
oxide.
happen before. Will you tell me what you're going to do?
That's right, Ben. And I will tell you everything that is going to happen. First, I need to put on my mask and gloves. These help me to not spread germs. I'm also going to put a paper bib around your neck. This will keep your clothes clean. You there, can you find and press on my mask, gloves, and the paper bib for Ben? Now, Ben, it is time to get ready to wiggle out one of your teeth. There are two tools that dentists use to help you stay comfortable.
So you see, by reproducing that video or other videos pertaining to what we're going to be doing at home in a non-threatening environment helps familiarize the patient with what's going to happen. Modeling, patient observes a non-action individual. So, you know, he will come close, not so close, but incorporation of observed coping strategies into a patient's own behavior is really important. Enhancing control techniques can also be enhanced by non-contingent breaks. Fixed time schedule of 10-second breaks was able to reduce the verbalization and untoward movement in children 2 to 9 undergoing restorative dental treatment. We do that a lot with our patients as well. We count up to 5 just to get an explorer in the mouth. And then this repetition of 1 to 5, it calms the patient, and then you can do more things on it. Distraction aims to divert the patient's attention from what may be perceived as an unpleasant procedure. The theory of distraction is based on the fact that the capacity of humans to pay attention is limited. I hope you're not falling asleep, and I would like you to check this video and check yourselves on what it says.
How many passes does the team in white make?
So I'm sure everybody has a number for me. Unfortunately, we can't get all the numbers back, but everybody was focused, unless some people have seen this video before, everybody has focused on measuring ball passes. But can you tell me who has seen this man dressed as a bear going through the players all that time? So if, you can Google that and find it and look back again. Or what I can do is I can show you one more time the video, and now you can, oops, let's see if I can go back. Yeah. And now let's see if you can find this.
Does the team in white make?
If you can find this, now that your focus has changed. So distraction is a very powerful tool. And we used that in a small project that we did at King's to evaluate the use of virtual reality glasses, which is a simple and immersive audiovisual distraction tool. We use it a lot nowadays in children. If they allow us in special care patients. And we show some relaxing videos like this. And then we do some sensory stimuli, and we saw that the people with the glasses, it was the 2D versus the 3D, because they always wear the virtual reality, but in one, it was just a static white frame, and in the second one, it was the video that you saw. The random effects of all these things, that the stimuli that they did, the odds ratios were double for the 3D. So, and we know now we do targeted stimuli with virtual reality for vaccines. This is a video of a company in Portugal, in Brazil. So they are showing, and I know now there is groups out there that are building specific software for dental practices. So the nurse will follow the action and does at the same time that you see the video.
Bem rapidinho. Peraí, deixa eu pegar aqui. Vai, escudinho, vai, escudinho. Funciona, funciona, funciona. Obrigada, obrigada. Caramba, filho, o que você acha disso? Legal. É a primeira vez.
So you see, a lot of things can be done. Again, here, distraction by watching Peppa on the ceiling. Oh, sorry again. And finally, as we said, we need to have painless procedures in order to continue. And
Κάτσε μπράβο ρε μπαγάσα, το φοβερότερο χαμόγελο. Είσαι καταπληκτικός.
And the same thing with distraction. So what we need to have empathy, as I said at the beginning in the list, we have to create an environment in which the child feels safe, use a kind, empathetic approach using directive guidance and reinforcement to establish cooperation and obtain rapport, allow the child or the patient some control with a hand signal, and you always ask, are you all right? Are you okay? Are you getting tired? And now a little bit about nitrous oxide inhalation, which is one of my favorite topics, is the most ideal sedation technique because it enhances effective communication between a patient and a healthcare provider. And in doing so, it is a sedation technique because it's a drug, but it's actually a behavior modification technique. It will require cooperation and patent upper airway. It's very helpful if we have a child or a patient with muscle spasticity or cerebral palsy. It's very helpful when we have gag reflexes. It will increase the pain threshold, and you rarely need more than 50% in order to work. And this is again a group of French that they did a paper with sedation with 50% nitrous oxide for outpatient dental treatment with individuals with intellectual disability. 605 dental treatment sessions, no serious adverse effects, 91% success rate. You can see up here, the group, 30% of them were autistic behavior or psychiatric behavior with a success rate of 87%. So it's very important. Nitrous oxide, a lot of things can be done with nitrous oxide, especially if the patient will be able to put the mask in the mouth and comply with the need to breathe continuously through the nose. What we do to these cases, we give the patient a mask to train at home, and that will increase the acceptance of treatment afterwards. So you see here, he's a little bit fighting, but then after he starts breathing the nitrous, you can perform the treatment with no problems. This is another special patient with, as you can see, a lot of cavities. This was supposed to be a general anesthesia case, but she managed to have the mask on. It was difficult at the beginning to learn to breathe through the nose, and you see the resident there trying to have her close the mouth. What we can do sometimes, we can have a wet handkerchief and put it on top of the mouth. So without actually blocking the mouth, we create a sensation that will be licking the wet handkerchief, but at the same time, it will force the patient to breathe through the nose. So that's another trick that we'll use if we can't do that. And this is after finishing. See, has her little doll with her. Mom is asking, are we coming back? We'll come back. And this is the amount of work that we did under nitrous oxide inhalation sedation. A little comment about nitrous oxide and MTHFR gene mutation. There are some negative systemic effects from abnormalities of the folate metabolism in patients with autism. And a lot of times, if they know that their child has a gene mutation, MTHFR, they will be concerned and refuse the use of nitrous oxide, although it's not really clear whether this has an impact, because before we knew about this, there's been a lot of nitrous oxide given to patients with these mutations without any adverse effects. But in any case, if there is this is something that is now in the literature, and we should be careful to the thoughts of the patients and their parents. A little comment about COVID and nitrous oxide. Nitrous oxide inhalation sedation will continue to play an essential role in dental practices for anxiolysis, and will become even more essential in managing children with uncalm and fidgety behavior who pose a threat of contamination. Nitrous oxide inhalation sedation does not add to the existing risk of exposure to a dentist, which always exists from various respiratory droplets. We're talking about patients that we don't know that they may be already positive with COVID without knowing it. If you need some more information about nitrous oxide, this is the clinical handbook that we did with some, and I was one of the editors for that. I will talk a little bit about, since we have time, I will talk a little bit about protective stabilization. This is a really interesting question mark, whether we should go to physical restraint or what I would call pharmacological restraint or sedation. This is advanced behavior management. Somebody needs to be well trained in order to do it. As the guidelines for protective stabilization in the American Academy of Pediatric Dentistry said, any manual method, physical or mechanical device, material or equipment that immobilizes or reduces the ability of a patient to move is what we call protective stabilization. Restructuring the sensory environment with immobilization by a restrictive device. This is particularly important with children with autism. There is anecdotal evidence from many therapists that the weighted vest, deep pressure vest or weighted blanket may assist with reflex maturity, body position and coordinations, hearing and speaking skills. The touch as a reinforcer may be very important for some patients. That can be a blanket or an apron. There's been also what we call dog therapy, that the patient will be with a dog on the dental chair and be relaxed, taking the breathing of the dog and relaxing. So protective stabilization as a coping mechanism is a form of behavioral guidance. It will decrease risk of injury while allowing for safe completion of treatment. It can be active mobilization. It involves restraint by another person, such as the parent or medical personnel. Here you can see Kyriakos. He's really relaxed in the arms of his mom. At the same time, he's controlled any untoward movement. Kyriakos is an autistic child, but it helps deal with the treatment. Passive immobilization, of course, is what we call the papoose board. It may be required when we need an urgent diagnosis or treatment as part of a procedural sedation, when the patients exhibit uncontrolled movements that can jeopardize their own safety and that of the medical staff. And actually, as we said, the passive protective stabilization may in fact calm the patient due to the deep pressure produced. You can see here, this is again a little autistic child. See how good he is with the big blanket, the apron, the protective blanket for the X-ray. And he came the first day because we had to do a pulpotomy as an emergency, and he would be a little bit uncomfortable, so we put him in a little papoose board. So it was a treatment of 5-10 minutes after we did the anesthetic. It was a hot day. That's why the paper's on his head. Mom was with him. And as soon as he gets up, he hugs, again, I'm sorry about this, we just hugs the resident, the assistant. You can see he's wet, he's thirsty, doesn't really remember or has any issues. And he's the same child that the next appointment he comes to have, it's the anesthetic, he comes to have the X-rays and a regular cleaning. So you see that the papoose board didn't really affect him. And in order to do this emergency treatment, we either had to find a place in the hospital to do either IV sedation or general anesthesia. With the papoose board, we dealt with the problem right there and then, and we still have a patient that has no issue. Here's again doing cleaning the next appointment with no papoose, And as I show you also doing the treatment. So no effect of the pappus board with the treatment. And there is this from the Formosan Medical Association, this is again from Taiwan, physiologic and behavioral effects of pappus board on anxiety in dental patients with special needs. Pappus board as application of deep touch pressure, sensory adaptation technique. As a sensory adaptation technique is not harmful for dental patients with special needs. Parental presence is really important because it will improve acceptance. Parents are usually more accepting of restraints when they're personally involved. Of course, there's been a shift from the pappus board and mothers' attitudes. 90% of mothers approved the use of the pappus board back in 1991. 96 thought was necessary to perform dentistry. 78 did not think it had a latter negative effect on the child. 86 were willing to use it for their next child. And this is 2005. And you can see the difference now is dropping to 50%. Is again what I was discussing about the new cultural environment that we have to deal with. And of course, we can do immobilization with special restraints, not exactly restraints, to relax. And this is me in Norway trying some new cushions, which were really relaxing. So patients coping with a medical procedure and procedural distress have previously built their own cognitive constructs that will strongly influence their responses. Therefore, no single non-pharmacological approach will be equally effective for all patients. It's very important to have a careful history taking to discover their individual procedure-related constructs. And non-pharmacological techniques to support patients with intellectual developmental disorders to receive dental treatment. That is a brand new article. And you can see here that the comparison of the behavior, demonstration of the behavior, reward and threat, restructuring of the physical environment, restructuring of the social environment, and distraction were the one behavioral change techniques that they were more important and more appropriate. So do minimize waiting times, warn before making physical contact, get a lot of information from parents, speak quietly and gently, recognize that the patient may not wish to communicate, offer preferred foods when possible, give clear explanations, minimize disruption, provide a clear plan for the day ahead. Do not allow prolonged waits and noisy environments, initiate physical contacts without assent of the patient, make assumptions about a child's understanding and cooperation, raise the voice, assume that lack of communication indicates lack of understanding. Spring surprises, routine is very important, and do not use complex language. So this is the treatment options line. You start with a good rapport, good local anesthesia. You can use behavior modification and psychological treatment. Nitrous oxide is right next to behavior modification. Physical supports, as we explained how to do it. Minimal sedation, moderate sedation, deep sedation, office or hospital GA, depending. This is our last resort in order to treat patients with disabilities. Now, treating doesn't always mean that we have to treat right there and then. There are ways to postpone treatment till a patient is more cooperative, or at least at an age that general anesthesia will not produce developmental issues if we have a very young patient that we need to deal with. Surgical restorative work in young children and those with special management considerations often requires advanced pharmacological behavior guidance. These pathways of care have additional health risks and limitations. Possible effects of brain development often are not accessible because the child is far away or not at a timely manner, like the patient I showed you with a push board. We also need to rethink traditional approaches that focus on the surgical management of caries. So this is a special patient that underwent general anesthesia to treat caries, even put space maintainers. And this is the situation after a year or so after the general anesthesia treatment. So you see that although it wasn't my patient when they first did the first general anesthesia, but the practitioner tried to deal with the disease, but actually dealt with the surgical treatment of teeth. And this was obviously not enough. So we have to rethink when our house is on fire, we are thinking of a carpenter to fix the couch. Well, first we need to get the fire off. So this, I think, is the exact discussion when we're talking about caries and infectious disease, because although extensive efforts have been made to teach to perform caries management under a minimally invasive, non-invasive, micro-invasive approach, the drill and fill approach may still remain predominant. So the modern day caries management is patient-centered, risk-based, prioritized prevention, early detection, is non-invasive and micro-invasive treatments. So the old paradigm of surgical drill and fill is just deal the consequences of the disease. But then we had the later paradigm, which was prevention, but prevention for one size fits all. The current paradigm is early intervention, risk assessment, anticipatory guidance, individualized prevention, and disease management. So, of course, I'm talking basically about SDF, cavity fighting liquid, lets kids avoid dentist drills. It's inexpensive. It's 38% silver fluoride salt. Has a high LD value, so basically no toxicity, no adverse effects so far. 2/3 of all dental caries lesions were found to be arrested after treatment. It's very easy to deal, even if you have a really non-cooperative patient, really fast.
I'm sorry, Professor, you still have 2 more minutes.
Okay, thank you. So I will basically go through this that we kind of already know, and also the whole technique that we use now in order to cover, again, is another way of dealing with caries. Very easy to put a crown and arrest the caries. And here you don't even need a newer to revisit the case. This is the whole technique in an autistic child. There is already now my silver tooth. There is already in the widget symbols that you can give to the autistic child to see. I'm not going to go into the malocclusion and crowded teeth, but is just that I wanted to show you, and I'll go sort of straight to the end of this. It's one mom's, it's the question also whether we should have orthodontics on patients with special needs. And this is a mom. When we first consulted her, I was concerned only about Chris' dental health. The irregular arrangement of his teeth, thanks to his trauma and Down syndrome, made me wonder how long he would have any teeth. The transformation which began 18 months ago is beautiful. We're not just talking dental health. Chris has gotten so much more. Is it worth putting a child with a disability through this? Yes. These kids have a future. All of Chris's doctors have made his process much brighter. My son hasn't stopped smiling. We have to see even the children with special needs or the adults with special needs deserve to be at least evaluated for orthodontic treatment and see what we can do to ameliorate the situation. Orthodontics is the art of the possible, not the science of the improbable. As we said, the orofacial issues is also a very big problem in what we discussed at the beginning, the international classification of functioning. So we need also to take this into consideration and not think that, oh, this is a patient that does not deserve an orthodontic evaluation. Thank you so much for having me. I can say Selamat Musim Panas. Happy summer to everybody. And looking forward to all your questions, either by email or live now. Thank you again.
Okay, thank you, Professor Emmanuel, for the interesting presentation regarding special care dentistry, specifically in how we treat the patient. And also my highlights say that reframing disability. That's mind-blowing, actually. But apparently, we have some question in the chat box. I will read it for you, Professor.
Thank you.
From Dr. Fania Cristiani. Yeah. Thank you, Professor Dimitris, for the good lecture. My name is Fania. I'm resident of pediatric dentistry, and I want to ask, or could you share about your experience about how to handle a special need patient who has a tantrum and didn't want to open his mouth, and patient had a trauma to the dentist before? Thank you. Please, Professor Dimitris Emmanuel.
Oh, well, that's, thank you for that question, but in order to answer it, I need 1 more hour.
Okay.
First of all, I need to know, how old the child would be, who is with him, if what exactly the special need is. So I'm afraid it's very difficult to answer that particular question without giving a really broad answer, because, as I said, every patient with special need is one patient with special need. You cannot put him in a group. You cannot deal with him thinking as a group. You have to go target and isolate and see what this particular patient, why does he have a tantrum? What happened in the previous? So this should have been known previously. So your history should be taken to what happened in the previous dentist, why he had a tantrum, what type of issues he has, what type of treatment you need to do and you plan to succeed. Is he in pain now? So you have to deal with him because he's in pain and you have to get him out of pain. And then, as I said, the treatment line that I presented at the end, you have to kind of pick what you think is appropriate for that person. So it's very difficult. If you want answer for that particular one, you can send me an email and maybe I can give you some more specific answers to that.
Oh, okay. Well, yeah, special need children is special, right, Professor? So maybe we need specific answer for each patient.
Exactly. The most important is know the history, know the medical history, the dental history, the social history. It's like a puzzle. You have to put a lot of pieces of a puzzle. Then, if you're lucky enough not to have to deal with it as an emergency, because the patient never been to the dentist or has been to the dentist 2 years ago and now he has a toothache that you need to address, And again, with the new ways that we can do, maybe even a glass ionomer, I just thumb through them at the end, could solve the situation. But again, it's very isolated, so it has to be a specific patient with a specific age and a specific problem in order to answer exactly what I would do. And obviously what I would do doesn't mean that somebody else could have done something else. Also, depending on what's the environment. Are you in a private practice? Are you in a hospital? Do you have a sedation available? Do you have nitrous oxide available? So all these are the factors that will puzzle in.
Okay, Professor, thank you. Maybe later, Dr. Fania will continue to contact you about her
That'd be
question.
great. I would love that.
Okay, the next question is from Dr. Lila Sari. Thank you for your presentation, Professor Dimitris. I want to ask about how long we should try to treat a patient with special needs in dental unit until we'll finally decide on general anesthesia. Thank you, Professor.
Again, it goes to the same. Again, there was a slide that said you have to identify what you hope to address. So you have to consider all the options, but not try all the options. In other words, you have to decide after seeing the patient, the medical history, what type of problems he has, what type of work he needs to be done. Is it like I showed you this case with nitrous oxide? This lady probably would have been, let's say, better under general anesthesia, although we managed to do her under inhalation sedation. But if her mother said that, listen, I cannot come 6-7 times to the dental clinic and I need to deal with it because I live 200 kilometers away and I can't come every, I don't know, week or 2 weeks to treat my child, then we would have to consider the general anesthesia option. If there's only one filling that needs to be done and the child is young or the filling is, the caries is not so extensive, maybe just addressing it with SDF till and revisit is a better option than having to put in general anesthesia. Again, everything has a cost. General anesthesia has a risk, a cost, and you cannot put somebody under general anesthesia to just do a filling that you could prevent by SDF, for example. So again, is a matter of taking all these considerations and decide what's best for that particular patient. And it's not only, you don't see only the mouth and that particular thing and think, oh, it's a drill and fill. I cannot drill and fill, then I will put my patient under general anesthesia or inhalation sedation or something else. It's a patient that he has to have good oral health functioning, ISF, International Classification of Functioning. He doesn't care whether he has caries or not. You care whether he has caries or not. But that shouldn't be your primary interest. Your primary interest is that he's out of pain, he's not going to have any other issues, that he can chew, that he can be with his friends. That's what that means to be a good doctor, not to have a good feeling. Obviously, if eventually the treatment is the filling, you have to be an exceptional good doctor to have a feeling that is not going to have caries again, or is not going to have an issue with the pulp and everything. But this is taken under, this is a given. You have that. Is the rest of the things that you need to evaluate.
Wow. Okay, Professor. That's actually, I feel like it's an excellent answer actually for this case. Yeah, I think so many considerations that have to be think by our own mind to treat the special needs patient. Okay, the last question, Professor, from Dr. Naninda. Good afternoon, Professor Emmanuel. A very inspiring presentation about nitrous oxide sedation, since it has a bad effect on the environment. Is there any way we can reduce climate impact of nitrous oxide in dentistry? Thank you.
Yes, thank you about this as well. This is also a rather, I totally understand the climate issue, but you have to think that nitrous oxide is a gas that is being used in a lot of industries. It's used in the agriculture industry, all these pumps that we have for foam, and they use nitrous oxide. So the industry gases, emission of nitrous oxide gases is 90 something. I don't remember the numbers. It's very easy to Google it right now. So the medical nitrous oxide, and from that, the dental nitrous oxide is only a very, very small part of the emissions of nitrous oxide that we're having in the environment. Now, to add a little bit more to this, there are now traps in the big hospitals, and because obviously it's expensive to do that in the private practices that have only 1 unit of nitrous oxide, and they're using practically liters of it every week. But there are now traps that they will disintegrate the nitrous oxide. So it's not going to go to the atmosphere. So yeah, this is basically for the medical nitrous oxide and the other medical gases, and along with it the nitrous oxide that they are in big hospitals. Obviously, technology will continue, and hopefully they'll have some smaller units that it will evade that. But as a whole, and as of today, the actual emission of our bad influence on the environment, on the climate, as far as nitrous oxide is concerned, is very minimal.
Oh, I see. Okay, because Dr. Nanin is head of special care unit in our hospital in Universitas Pajajaran. So I think the nitrous oxide should be her consideration.
Yes.
Okay, I think, Professor, one more question, I guess. Yeah, the last question from Dr. Alia. Thank you, Professor Emmanuel, for this insightful lecture. I am Alia, and I'm one of the pediatric dentistry residency student. I would like to ask a question regarding shifting the paradigm of seeing the special needs patient. As pediatric dentists, what are the competencies that you can do to treat special needs patient in older age? If we have homeless or immigrant young patient coming into our office together with their parents, which were classified as special needs patient, what can we do to help them? Thank you, Professor. Interesting cases.
Yes, that's again, there is, and this actually is shifting, because now we have a lot of universities, a lot more than we used to have, that they are actually having special care as a specialty. So in the previous, when I was in training, actually pediatric dentists were actually the only ones that were treating special care patients. Obviously they were starting from childhood, but then all of a sudden you had an 18 plus patient that nobody would be able to treat. So we ended up at seeing these patients because, and I made a mention, you may have an 18 with intellectual disability that is actually pretty much like a 5-year-old. So it comes to a pediatric dentist to deal with him. But then at the same time, this patient may need some prosthetic work or some other things. So you need to have interdisciplinary approach. Again, is a matter of where you are. If you are in a private practice and you are a pediatric dentist, again, you have to do the best you can for your patient. even if he is adult, you cannot say, well, you're an adult, I'm not going to treat you. You have to deal at least with the emergency till you find him what we call a dental home, right, for this patient. There is this is a big problem in moving our older patients from our pediatric care, where they're used in a state-of-the-art care, because pediatric dentists are really good practitioners and dentists, in order to move to a new patient, especially these patients with special care, that they are used to being treated by the same doctor for many years. So the environment plays a big role. Again, is a matter of personal decision making and environmental. Where are you? Are you near a hospital that maybe they can transition to a hospital? And I'm not sure how in Indonesia the dental care is being taken care of, and how much the state can do and how much is private, and vice versa. So again, I'd like to give more definite answers, but unfortunately we could be talking a lot, but again, it needs to be addressed as a specific, with a lot of specificities on that particular place, like where is your practice, what type of practice it is, what do you do there, what can you do?
Well, I hope we can have another session with you, of course, Professor. Okay, I think you have answered all the questions. Thank you Professor Dimitri Emanuel. Is there anything else you would like to mention or highlight from your presentation?
I'm very happy and very surprised with how much special care is part of the dental school, and I really would like to at a certain point on my way somewhere to stop by and really congratulate you for what you're doing. It's one of the few dental schools that I know are doing so much for special care. It's not a secret that special care is not glamorous, and a lot of dental schools, especially in our part of the world, they prefer more implants. And when I was at the dental school in Athens, we were trying to change the curriculum, and we were trying to find hours to substitute special care for other disciplines. And obviously all the disciplines were saying, no, this is very important for us. We can't give you more hours for our students to do special care. So I'm really happy that this is not the case here.
Thank you, Professor. We hope to see you in Bandung, Indonesia, really soon.
Thank you. Thank you again.
Okay. Thank you very much, Professor Emanuel, for the enlightened presentation. I feel so honored to be your moderator for today.
The honor is mine. The honor is mine.
We also hope to see you again in the future. The next session, Professor. Selamat hari.
Thank you.
Okay. We're looking forward to visit Indonesia, maybe after the pandemic.
And if anyone can make it to Paris, I'll be happy to meet him. You can send me an email.
Okay. We hope so. Once again, thank you, Professor. And then that's all the session for this afternoon from Indonesia, and this morning from Paris, maybe. I hand over the session back to MC. Dr. Naninda, please, the time is yours.
Thank you, Dr. Prima. Since we are running out of time, we are moving forward to certificate handover for our speaker, which will be presented by our Vice Dean, Dr. Susi. Are you with us?
Okay, Dr. Nanin, thank you.
Okay, to our host, please do the certificate.
Yeah, on behalf of the faculty, I would like to present the e-certificate as our gratitude to you, Professor Dimitris. Thank you for sharing your excellent lecture. I hope there will be further collaboration between the Faculty of Dentistry Universitas Pajajaran and Dental Kids London. Thank you, Prof. Thank you, Dr. Nanin.
Okay. Thank you very much, Prof. Emmanuel and Dr. Susi. And the next certificate handover is for our moderator, which will be presented by Professor Dr. Arlet. Prof. Arlet, are you with us? Professor Arlet, are you with us, Prof? Okay, maybe Prof. Arlet is in trouble with connection. Dr. Risti, is there an Dr. Risti, are you still with us? Oh, Professor Arlet. Hello, Prof. I think the connection is, you're in a bad connection, Prof.
Okay, sorry.
It's okay.
I think my connection is very poor. Yes. Sorry, pardon. Can you? Okay. Okay. I'm sending this certificate for the moderator, Uma Adisantianto. So please receive our gratitude for this session. Thank you very much.
Thank you very much, Professor.
Okay, thank you very much, Prof. Arlet, Dr. Prima, ladies and gentlemen. May we invite Dr. Gigi Asep Daria Dharma Putra to deliver chanting prayer.
Assalamualaikum warahmatullahi wabarakatuh. Before we close this lecture, allow me to invite all participants for praying to Allah for His blessing to all of us in this lecture, and allow me to guide this prayer in Islamic way. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Allahumma shalli ala sayyidina Muhammad wa ala ali sayyidina Muhammad. Rabbi shrah li sadri wa yassir li amri wa hlul 'uqdatam min lisani yafqahu qawli. Allahumma inna nas'aluka salamatan fid din, wa afiyatan fil jasad, wa ziyadatan fil ilmi, wa barakatan fil rizki, wa taubatan qablal maut, wa rahmatan indal maut, wa maghfiratan ba'dal maut. Allahumma hawin alaina fi sakaratil maut, wa najata minan nari wal afa indal hisab. Rabbana la tu'akhizna in nasina aw akhtana. Rabbana wa la tuhammilna ma la taqata lana bi. Wa'fu anna waghfir lana anta maulana fansurna 'alal qaumil kafirin. Rabbana zalamna anfusana wa illam taghfir lana wa tarhamna lanakunanna minal khasirin. Ya Allah, today we have organized a visiting lecture, a collaboration between Universitas Pajajaran and Dental Kids London, with your blessing and permission. Thank you, God, for all the good lessons we learned today. We hope that the lesson we learned will be beneficial for us and our future. Ya Allah, thank you for loving us with good health, and so we can learn new lesson today in great spirit. Today is a great learning experience for all of us. Please allow us to be more understanding of the lesson even from before. Thank you for allowing us to learn something new and make us richer with information. Ya Allah, Ya Ghafur, you are the most forgiving of all sins. Forgive our sins. Bless us in the protection of your mercy and forgiveness. Ya Allah, Ya Mujib, you are the one who answers prayers. Please grant our prayers. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Asep. Before we end this session, maybe we could take a picture together. To all of the participants, please open your camera. Okay, from slide 1. Okay, 1, 2, 3. Okay, and the second slide. 1, 2, 3. Okay, thank you. Okay, once again, on behalf of the committee, I would like to thank all of the supports from International Office and Pediatric Dentistry Residency Program, Faculty of Dentistry, Universitas Padjadjaran. Ladies and gentlemen, we are at the end of our program. Thank you very much for all your participations in this lecture. I wish you all great success in your pursuits. Have a great day. Assalamualaikum warahmatullahi wabarakatuh.
The Pediatric Dentistry Specialist Program, or IKGA, is a residency program that focuses on dental and oral health care for children from birth to 18 years of age. The study period for